All right, I know some folks are still joining us, but we'll go ahead and get started. So hello, everyone, and welcome to today's conversation series program, where we'll do a deep exploration into the variations in hospital policies surrounding donation after circulatory death. My name is Deanna Fenton, Senior Manager of Program Development and Operations here at the Alliance, and it's my pleasure to be here today to kick off our discussion. Now, for those of you who may be new to the Zoom platform or maybe new to our programs altogether, I'd like to encourage you to take this opportunity to locate the chat feature, which is located at the very bottom of your Zoom window. Now, over the course of the discussion, we welcome you to submit any questions or comments you may have for our presenter. We'll do our best to address as many questions as time allows. Now, additionally, if you happen to be using this as a group learning opportunity, we're going to go ahead and launch a poll and ask that you take a moment to complete the poll to indicate approximately how many people have joined your group. Now, to get us started, I'd like to go ahead and introduce our moderator, Erin Vines, who serves as a clinical research associate at Southwest Transplant Alliance. Erin, we thank you so much for being with us to lead the discussion today. And at this point, I'll go ahead and turn the floor over to you.
Great, thank you, Deanna. Good afternoon, everyone. And I want to thank the Alliance for allowing us and inviting us to present today. Also want to thank everyone on the line for taking time out of their day to join us. I hope you find the presentation interesting and educational, and maybe even provide you some framework to take back to your individual institutions. I was excited to see so many engaging questions posed during the registration period. We've done our best to include most of those in the presentation itself, but if we missed anything or anything else comes up, please feel free to throw those in the chat and we'll get to them a little bit later on in the presentation. So our topic today, like Deanna mentioned, is the variation in DCD policies across a single OPO's donor service area. This is a project Dr. Wall and I worked on about a year ago, and it provided us with some pretty interesting insight. But it also allowed us to see how important a healthy relationship is with your transplant centers and all your donor hospitals, how important that can be, and that it's imperative to a successful donation process. So with that, I'll introduce our speaker for today. Dr. Angie Wall is an abdominal transplant surgeon and bioethicist at Baylor University Medical Center in Dallas, Texas. She's also the Vice Chair of Research at Baylor-Simmons Transplant Institute. Her research interests include transplant policy ethics, cost considerations in transplantation, ethical and clinical questions in uterus transplantation, and qualitative studies of transplant patients and providers. Her clinical work focuses on living and deceased donor liver, kidney, and uterus transplantation. So take it away, Dr. Wall.
Okay, great. Let me pull up my screen here. All right, just need verification that you guys can see a PowerPoint. All right, great. Thanks, Erin. Okay, well, thanks so much, Erin, for the introduction. And as Erin said, this presentation is a project that we worked on together along with some of my other colleagues here at Baylor Scott & White in Dallas, as well as some of the other folks at the Southwest Transplant Alliance. So not only is this specifically about donation after circulatory death policies, but it's a good demonstration of how OPOs and transplant centers can work together to improve processes and procedures around different various aspects of organ donation and transplantation. So just to get started, what I am going to talk about today is a few of the historical perspectives on DCD organ donation, just so that everybody's sort of on the same page with what we mean and how this, how DCD has progressed in the United States over time. I'm going to talk about DCD processes, again, to make sure that everybody who is listening has a sense of what I'm talking about and how donation after circulatory death is different than donation after brain death. I'm going to talk about the ethical framework for how we analyze DCD donation processes and procedures, and then talk about how that ethical framework sort of fits into the way that policy variation is currently happening. And finally, talk about how we can move toward best practices in DCD policy in order to have better donation experiences for our hospitals, our families, and our transplant programs. So to get started, donation after circulatory death is organ donation from individuals who are pronounced dead by cardiorespiratory criteria. And it's actually categorized into 4 different categories. So there can be individuals who are found down. That's typically not what sort of circulatory death is amenable to DCD donation, but there are some places that deal with witness arrests that can be in the field that can then transport individuals to a hospital setting, and in some places that is known as uncontrolled donation after circulatory death, and it can be an opportunity for organ donation. And then there's withdrawal of life-sustaining treatment, or also known as controlled donation after circulatory death. And what I am focused on today, because what we do in the United States almost exclusively is this category 3 type of donor. So withdrawal of life-sustaining treatment, which is a controlled donation after circulatory death. So if you look at the history of DCD donation in the United States, it actually came about before brain dead donation. So in 1962, the first deceased donor kidney transplant was done in the US, and that was from a donation after circulatory death donor. Brain death criteria wasn't developed until 6 years later in 1968, and this was through the Harvard Ad Hoc Committee. And many of you are probably familiar with the paper that came out that discussed both brain death criteria and the implications of brain death criteria on organ transplantation. So from the end of the 1960s through the 1990s in the US, brain dead donors were the preferred type of deceased donor to use for organ donation because of the fact that these donors were able to be kept, the organs were able to be kept perfused on mechanical support, right? On mechanical ventilation, along with pressor support and other things when necessary. And so it is and was a very controlled way to do organ donor procedures. You have all the time in the world to work up the donor, allocate the organs, and kind of figure out the logistics of how the donation is going to happen. However, only about 8% of people who die in a hospital are pronounced dead using brain death criteria. So that means 92% of the people who die in hospitals die of cardiorespiratory criteria. And so if we only focus on brain death as the pathway to organ donation, we do not have the opportunity for most of the people who die in a hospital to potentially be organ donors. And we have a very small pool of organs for transplantation. And when the Institute of Medicine recognized this in 1997, as organ donation had become, or organ transplantation had broadened in scope and become more successful, and the supply of organs was much less than the demand for organs for transplantation, the Institute of Medicine actually developed a whole book about what's called non-heart beating organ transplantation, which we now know as DCD organ transplantation. And this book chronicles both medical and ethical issues in the procurement of DCD organs. So this was kind of to talk about bringing back DCD organ donation to increase the pool of donors. And this particular book focused specifically on the medical issues, or so the ethical issues in procurement, and ultimately came to the conclusion that this is both a medically feasible thing to do, and that the ethical issues, while they are there, and we'll talk about that in a little bit, that this practice is ethically acceptable. Now, you can't really do DCD donation, or you can't functionally make it work without having your critical care providers on board with this, because it takes a lot of collaboration between your OPO and your critical care physicians to make DCD donation work. And so in 2001, the Society for Critical Care Medicine endorsed DCD donation, and that was sort of a huge step forward for the potential for DCD donation. And then following about 5 years later, the Institute of Medicine published another book about organ donation, and this one was about opportunities for action. It was actually specifically focused on opportunities to expand organ donation, and one of the focal points of this book is how DCD donation has or had the potential to increase the pool of organs available for transplant. And so if you map some of these sentinel events onto the timeline of where of the number of DCD organ donors in the US by year, you can see that the IOM report, while it started the conversation, it didn't really move the needle forward, right? There were about 70, less than 100 donors, even a couple years out from the IOM report. But as soon as the Society of Critical Care Medicine endorsed DCD donation, you can see that the numbers start to go up pretty substantially. And then the IOM opportunities for action, you can see that those numbers just keep going up. And so, so having more endorsements and being more, and especially having the buy-in of the critical care community, I think has really improved the opportunities for DCD donation, the numbers of DCD donors. Now, the DCD process, and I think it's important that everybody sort of gets the main steps. And I know that many of you are from organ procurement organizations, and so this is something that's probably, something that a lot of you are familiar with. But I just want to make sure we're kind of all on the same page. So the process of DCD donation begins with the family's election to withhold or withdraw life-sustaining interventions. Next, what happens is they make the decision about authorization for donation or to support the first person authorization of their loved one for organ donation. So it's withdrawal of life-sustaining treatments. Next comes the decision about organ donation. Next is organ evaluation, allocation, all of that. Stuff. And then that individual is pronounced dead using cardiopulmonary criteria. And if that person dies within a given time frame that's acceptable for the utilization of organs, then those organs are usable for transplant. Now, to go more into the specifics about how the operating room kind of how it functions from withdrawal to determination of if the organs are going to be viable. I make treatments, and that starts what's called your total warm ischemia time. At some point, you hit parameters of either systolic blood pressure or oxygen saturation, where you start what's called a functional warm ischemic time. For liver transplant, at least for my center, we use a systolic blood pressure of 80 or an oxygen saturation of 80. But there are other places, like in the UK, for example, they use a systolic blood pressure of 50. There is unfortunately not a lot of evidence to really pinpoint what the best starting point for functional warm ischemic time is. But I think it's fair to say that everyone who does DCD donation has their starting point. The next point in the timeline is that there is a circulatory arrest, and at the point of circulatory arrest, that is when death is pronounced. Then there's a hands-off period, which is it's typically within the 2 to 5 minute range, and we'll talk about that when we talk about the different policy elements. And that 2 to 5 minute range is at the end of that time frame, there is confirmation of death, meaning that there is no auto resuscitation, no evidence that the heart rate started on its own or that the person started breathing on their own again. And if you confirm that there is no evidence of auto resuscitation, then the organ procurement team proceeds with incision, cannulation, and organ preservation, whatever mechanism of organ preservation they're planning to use. So your functional warm ischemic time goes from your systolic blood pressure or oxygenation threshold to the point of flushing the organs with preservation solution, or for normothermic perfusion protocols to the point of perfusing the organs at a given flow or pressure. But the total warm ischemia time starts with the withdrawal of life-sustaining treatments, which is typically extubation, but it can be taking somebody off of ECMO or other types of interventions. So when we talk about DCD donation, there are some things that separate DCD donation from donation after brain death. And I think it's important to note those points as we talk about the context of DCD donation and then the ethical framework for DCD donation. So the timing of discussion about donation, in donation after brain death, it's after the person has been declared dead by neurologic criteria. So that person is already dead. The organs are remaining perfused on ventilator, the heart is still beating, still on a ventilator, et cetera, but that person is already dead. For DCD, and I've put super rapid recovery DCD, but it's pretty similar to a newer technique called normothermic regional perfusion. They're pretty much similar. The timing of discussion for a DCD is before death, but it's after the decision to withdraw life-sustaining treatment. So you've got a family that's just made a relatively difficult decision about the withdrawal of life-sustaining treatment. And then the next question is about organ donation. Authorization for donation after brain death, it's really for donation, because anything you do in the workup for organ donation is done after that person has been declared dead. And so all of the things that are done are for the purposes of donation, whereas the family decisions for a DCD are not only the withdrawal of life-sustaining treatment, authorization for donation, but then you also have some questions about pre-mortem interventions that can be done. For example, is the family okay with doing a CT scan or a cardiac cath, or having the withdrawal occur in a different place? And so all those things, because that person is alive until the point where they suffer a circulatory arrest, all the decisions about pre-mortem interventions have to go through the family and the medical team. The temporal relationship of death to organ procurement for donation after brain death is typically days, whereas for DCD, it's within minutes. And that's because of the fact that you have to perfuse the organs relatively quickly so that they will be okay for transplantation. And so that also comes into the transition from patient care to donor care, that for donation after brain death, it's in the ICU when the decision to donate is confirmed, whereas in the DCD, it's usually in the operating room, and it's at the time of death or at the time of confirmation of death, you have a switch over from the team that is caring for the patient to the team that is procuring organs. It's basically an immediate switch. The operation for donation after brain death is typically more controlled. The heart is beating, and so it's quite it's quite controlled. Everybody does whatever dissection they need to do, and then there's a discussion about when we're going to cross clamp, and it's pretty straightforward. With DCD, you have to go fast. You have to have a rapid cannulation and perfusion. And so I always tell, when I'm in the OR doing a DCD, I always say to the scrub, I'm going to set up my Mayo. I'm going to do what I need to do for the first 5 minutes. And then once we get cannulated and we're good, we go back to being not so crazy. But the first 5 minutes of this operation is a little bit hectic. So you have to go fast so that you can get the organs perfused. Now, what that sets us up with is, what is the context of DCD donation? So number one, you have multiple decisions. You have the decision to withdraw life-sustaining treatment. You have the decision about authorization for donation, pre-mortem interventions, location of withdrawal, presence at withdrawal, et cetera. You've got a time-sensitive situation, so the organs can only be used for transplantation if the donor meets warm ischemic time limit. And then that transition from patient to donor happens basically at the time of death, or at the time of confirmation of death, and it's marked by the incision for procurement. And then this is what I would say is a high stakes situation. You have to move fast. You often have a lot of teams with sharp objects that are trying to procure different organs. And you also have to be very, you as, I'm speaking from the transplant side, you as the transplant surgeon have to put a lot of faith in the medical team that is pronouncing death, because that's not your job, and you can't be in the room when that happens. So you have to trust that they're going to pronounce and they're going to confirm in a way that is acceptable, and then turn it over to you. And you just have to you have to start your operation right away. So multiple decisions, time sensitive and high stakes, are kind of the context of DCD donation. And this is what sort of helps us set up the framework for the ethical evaluation of DCD donation. So when you look at the ethical principles, number one is respect for autonomy. And what respect for autonomy really comes down to is recognizing the complexity of the informed consent process for DCD donation. And making sure that sort of all the pieces are in place. And we'll talk about some of the policy elements that go along with respect for autonomy, and some of the standardization that we would recommend. Number two is non-maleficence, which is where we need to avoid harm to the potential donor, because that potential donor is a living person until the time when death is pronounced. And then you can change the behavior around that body, because at that point it is no longer, the body is no longer a living person. So we have to be very careful about harm prior to when death is pronounced in these individuals. And then next is beneficence. Beneficence is something that I don't think we focus on enough in DCD donation, but I think it's something that we should be transitioning toward, and something that I'm going to talk about as we talk about how we can make policies that are more suitable for DCD donation. And what beneficence comes down to is maximizing benefits and minimizing harms in what is termed the donor-recipient dyad. So I think of this as very similar to living donation. So when we do living donor kidney transplantation, for example, the donor takes on a risk in order to benefit the recipient. And there are things that we do to the donor to make sure that the recipient is going to have the best outcome. For example, we do a CT scan on all of our kidney donors to see if the blood vessels are amenable to implantation. That in and of itself, you wouldn't just do that to a healthy person for no reason, but because it maximizes the benefits and minimizes the harms to the recipient, then we do that intervention for the purposes of improving the outcomes of the recipient. And I think that we can think about DCD donation that way as well. We do things to the potential donor to improve the outcomes of the recipient in a similar framework as we use for living donation. So now what we're going to do is we're going to talk a little bit about how DCD policies, and DCD dogmas. So every hospital has to have a DCD policy. That's JCO requirements. There has to be a DCD policy. Now, I will tell you that not every hospital does have a DCD policy, but they should. Second, DCD donors typically stay at their admitting hospital for donation. So there are many OPOs that have created, that have built donor procurement facilities. Those donor procurement facilities are not suitable for DCD donation because you can only transfer donors there who are already dead. So only DBD donors can move to those facilities. So for the most part, not always, but for the most part, DCD donors do typically stay at the hospital where they're admitted. And so this is why every hospital has to have a DCD policy, and why we felt it was really important to look at DCD policies, because they impact our practice. DCD donation, as we will show you, is a low volume, high stakes procedure at most hospitals. And so because of the fact that it is low volume, policies should be detailed, clear, and in line with the ethical principles that guide DCD donation. That's a premise of our kind of what pushed us to look at DCD policies, is that this is a goal, right? If you have to have a DCD policy, if you are likely to have a DCD donor at some point, and it's a low volume, high stakes procedure, then you need to have a detailed process for how this is going to work, because it's not like you do this every day. Now, not only do places have DCD policies, I would argue that the even more complicated situation for anybody who's been on the ground on a DCD donor is that a lot of hospitals and individuals who work within hospitals have what I would term DCD dogma. So I'll explain it a little bit. And if anybody needs clarification, just let me know. But these are the things that I have been told as a transplant surgeon when I have shown up at a hospital. So I've been told that I can't prep and drape a potential DCD donor because it's unethical. Now, if you think about it, I prep and drape living people all the time. So my argument back to that is that, I prep and drape my transplant patients and they're not dead. So there's nothing about prepping and draping a living human being that is unethical, but there are people who feel like that is disrespectful to the potential DCD donor. We withdraw in the ICU because it's more respectful to the patient. Well, that might be the case that the ICU could be a better environment. But if you think about the downstream effect, that means after they've died, you're kind of running through the hospital with a dead body. That's also not really the most respectful way to deal with a DCD situation. So again, this dogma is very ingrained because the way that people think about DCD donation and the best practice for DCD donation, but it may not be. The next one, the procurement team can't enter the room during the hands-off time because it may pressure the pronouncing physician to confirm death. I can't imagine that being the case, but I've been told that. And if you can't enter the room, then you're like running into the room after confirmation, grabbing a knife and starting. And I think that compromises the safety of everybody in the operating room, everybody who's scrubbed in. So there are, again, pluses and minuses to this DCD dogma. I've been told that the anesthesia team won't re-intubate the patient because they don't want to assist with organ procurement. It's something that I didn't realize we needed to have on a checklist for DCD donation. And even if it's in the policy, you have to actually make sure that your anesthesia team at the hospital is comfortable. And then, I was at a hospital that told me that the sterile core wasn't sterile enough to be scrubbed in. And it wasn't just one person, it was like multiple people who came up to me to tell me this. And this is the practice across the country that that I do and I'm comfortable with. And they wouldn't offer me like another option. Like I couldn't sit in the operating room with this patient because that's not allowed. And so, there are some things that we just have to do for DCD procurements that might seem wrong through some people's lens of dogma in, sterility or whatever. So anyway, we notice that there is variation in the way that our different members of the team or the hospital where we go to for DCD procurements think about what it is and is not acceptable, whether or not it's in a policy or not. So given that we've had kind of wide variations in experiences with DCD procurements throughout our donor service area, we decided that we were just going to look at all the policies and see, is it really policy variation? Is it dogma variation? Is it both? What is happening? So here's what we did. We looked, Aaron found the number of inpatient facilities in our donor service area. There are 271. 146 didn't have the ability to do DCD donors. They're like skilled nursing facilities, places without ORs, stuff like that. So out of the ones that were not excluded, we had 125 that either had a policy in our database or the facility was contacted for a policy. We couldn't get 27 of those policies, and so we ended up with 98 policies to look at. 82 were from facilities that had referred at least one DCD donor within the last 10 years. 16 had never referred a DCD donor. And then you can see the breakdown of whether or not they were single or shared system policies here. If you look at our hospital characteristics for what policies we got, we did have nine transplant centers had policies available, but the overwhelming majority were not transplant centers. You can see some of the interesting. I think one of the interesting things is four of the centers that or hospitals for which we obtained policy actually transfers DCD donors. As I said, the majority of hospitals had at least referred one DCD donor, so that was about 83% of the facilities, but only 60 had completed one DCD. And again, this was within a 10-year time frame. And notice here, the median number of donors referred per facility was 6, and the median number of donors completed, again, within that 10-year time frame was 1. So what I would argue to you is that most hospitals referred less than 2 DCD donors per year. Most hospitals completed less than 1 DCD donor per year. And so, like I said earlier, this is a high stakes, low volume procedure that can honestly be done at any hospital, and it's usually done very rarely at any hospital. You can see that there are a couple of outliers. So there's this one 200-bed hospital that completed 50 DCD donors and referred, the numbers aren't on that timeline, but over 100 in the 10-year time frame. But then, there's a 500-bed hospital that completed less than 10 DCD donors. So the hospital size doesn't matter, and neither does transplant center status. So here are some of the things that we found. So number one, we looked at the question of when should a referral be made to the OPO. 75% of policies say that that referral should be made before the decision to withdraw life-sustaining treatment. 18% said that it should be after the decision to withdraw life-sustaining treatment, and 7% didn't mention when a referral should be made. Now, if you think about it, if you make a referral after the decision to withdraw life-sustaining treatment has been made, then the OPO is on a very short time frame to have the opportunity to review the history of the potential donor, to set up an approach for the family, and so forth. And so really, I would say the best practice is making the referral, not making an approach, but making a referral before the decision to withdraw life-sustaining treatment. Now, the next thing is a question, I found this question fascinating. So in these hospital policies, the question is who can authorize donation. So out of the hospitals, 90% said, out of the policies, 90% said that either a family member or a surrogate could be the person to to authorize donation. Just over 10% said that you could alternatively use first person authorization, which means either a driver's license or registry or something along those lines. One policy said that the medical examiner can make the determination about organ donation, and this is in the setting of DCD donation. And then just under 10% didn't mention who can authorize donation. And these are not mutually exclusive. As you can see, this adds up to more than 100. So some policies said family member or first person, et cetera. So the next thing that we looked at was what can be done prior to the withdrawal of life-sustaining treatment. And this is what can be done based on the policy, not what can be done based on what they actually do at the hospital. So if you go from the bottom to the top, you can see that the majority of places allow for prepping and draping the patient, heparin administration, studies for organ viability. They don't go into detail about what those studies are, and then consultations for organ viability. So all those things are allowed in more than 50% of the policies, specifically written in more than 50% of the policies that we looked at. We looked at femoral cannulation, allowing for femoral cannulation either prior to withdrawal or during that hands-off time period of 2 to 5 minutes. And we found that if you add it together, about 20% of policies allow for that to happen. And then transfer to a different facility was in 2 policies, and allowing for a cardiac cath, specifically written in the policy again, was in 1 of the policies that we looked like. So what we found is that there's some level of consistency in the sort of prep and drape, heparin administration, organ viability, but then there are some policies that are the minority that specifically allow for more things to be done prior to the withdrawal of life-sustaining treatment. we looked at some other variables as well that we thought would kind of define some variability. So we looked at the time limit from withdrawal of life-sustaining treatment to death, where a facility would allow the person to be in the operating room. The majority of facilities in our donor service area limit that to 60 minutes. About 26% allowed 90 minutes, and then 22% did not mention a time frame. And so it's not clear if those facilities defer to the OPO or if they have some sort of time frame that they use, but they just don't have in their policy. So I would argue that we're kind of on the more restrictive side in terms of the number, the time limit from the withdrawal. For most transplant programs will at least allow for like a 90-minute warm ischemic time for kidneys, and even some lung programs will go out to 90 minutes. And if you only allow that 60-minute time frame for being in the operating room, you have a potential for going through this whole process and not having any organs recovered for transplantation, where there would have been, had you left it a little longer, there would have been an opportunity for at least some organs to be procured for the potential for transplantation. Now, this is another one that I found kind of fascinating. How is death determined? So most facilities require palpation of a pulse. Once the pulse is lost, then that is adequate for the pronunciation of death. Some require a secondary or exclusively cessation of electrical activity on monitors. Some require auscultation instead of palpation, and then some don't mention it at all, and it's just however you pronounce death can be done at the same as as you would do in an ICU. So some policies are very clear and some are not very clear about the determination of death. We also looked at hands-off time. 60% of the hospitals in our donor service area have a 5-minute hands-off time from the declaration of death to the confirmation of death. 28% have a 2-minute hands-off time, and then 7% had either 3 or 4 minutes, and 5% did not specify a hands-off time. So the policy said hands-off time, but didn't have any amount of time that needed to be. So what I think, and what I hope maybe I can give you as some thoughts on DCD donation, is that DCD donation has always been, because of the going from brain dead donation to DCD donation, with the lead of the IOM, the focus was making sure that we maintained trust in organ donation, and we also avoided harm to the donor. And if you avoid harm to the donor, these are the things that need to be followed. We need to make sure that the donor is dead prior to the procurement of vital organs. We need to make sure that the same comfort care is provided to the potential donor as would be provided in the absence of donation. And then we have to be very thoughtful about our consent. All premortem interventions require consent. They need to be separate from the authorization for donation. And we need to have an avoidance of conflicts of interest, separation of the care team and the procurement team. But what I would say is that once we can meet that ethical lens, once we can avoid harms to the donor, then I think we need to be a little bit more forward thinking or inclusive, where we start to shift our focus from this harm avoidance to this more beneficence focused or a different type of harm avoidance. So what I would say is that there are a lot of harms to non-donation, and those harms can be to the family who is unable to fulfill this last attempt to make something good out of a tragedy. They lose that legacy impact of organ donation. Recipients miss the opportunity for transplantation. And then your transplant centers and OPOs incur the costs associated with dry runs. And so there are harms of non-donation kind of at every level. And what we can do is we can take what we know about policies and what we've seen in the variation in policies, and say, if we have a focus on the value of donation rather than the harm of donation, we can stay within this ethical framework of avoiding harms, but then we can also make policies that are more donation focused rather than harm avoidance focused. And so these are our thoughts or our conclusions about what would be the value of donation, or a more donation centered approach to policies. One is having the withdrawal of life-sustaining treatment in either the OR or the PACU, at least for the super rapid recovery donors. If anybody has questions about NRP, we have a little bit different, it's a little different experience, and I can explain why. Second, hands-off time, a shorter hands-off time decreases the functional warm ischemic time and increases the opportunity for donation. So if we don't have auto resuscitation within 2 minutes, we haven't proven that that will happen, then we should shorten our hands-off time. Total OR time, longer total OR time gives us a greater opportunity for especially kidneys and lungs to be procured. And then an expanded allowance for pre-withdrawal interventions with appropriate consent. Things like cardiac catheterization, liver biopsies, femoral cut downs or cannulations, all improve the opportunity for donation, because they give transplant centers more information to say whether or not they will accept that person as a donor if donation proceeds, or they allow for the donation, for the procurement procedure to go more quickly. Prepping and draping, if the person is in the OR, I would argue that we should be able to do that. It just takes one more variable out of the whole chaos. And when can the donor team enter the room, for example, like another example, probably after the pronouncement, obviously not in a way that intimidates the pronouncing physician, but at least to be able to get themselves close to the table and be ready to go if there is no evidence of auto resuscitation. So I actually wanted to leave some time here to see if anybody has any questions. And I know that we had a ton of questions that were submitted ahead of time. So what I'm going to do is leave about 10-15 minutes for questions, just say thank you, and hopefully this will prompt a little bit of discussion.
Thank you so much, Dr. Wall. Wonderful presentation. We don't have anything in the chat just yet, but I do have some questions here. Maybe we can start with these.
Okay.
What are your thoughts on how palliative care and the ethics team can influence policies in our DSA?
So a couple of things. So one, I work for Baylor Scott and White, which is not just one hospital. We have something like 44 hospitals across the Central and North Texas area, and our ethics, our systems ethics team actually spearheads a lot of policy development and policy modification for the system. And so after we completed this study, I actually went to the ethics team or to our ethics chairs, and I said, our policy is not really in line with what we would consider best practices. We should think about changing this. So we were one of the hospital systems that was 60 minutes and 5 minutes hands off. We changed both of those things. And then we also updated the policy to have a very detailed process, recognizing that there are small hospitals that rarely do DCDs that need a more detailed approach. And we added some more language about the acceptability of pre-mortem interventions with the consent of the family. So, so that is one thing that ethics can absolutely help with policy changes. And then from a palliative care standpoint, we actually have a lot of overlap between palliative care and ethics. So both of the chairs of our ethics program are palliative care specialists. So they have been very involved in the policy development. But then the other thing that we have been working on as a team is actually having palliative care as a bridge to the discussion about organ donation. And the reason that that is important is that when you talk about the withdrawal of life-sustaining treatments, often after the family has made a decision that they're like, yes, we want to withdraw, the next question is, well, what's it going to look like? Do you want me to tell you what it's going to look like? And if you don't have some sense of what DCD donation looks like, then your discussion is going to be focused completely on what withdrawal in the ICU in a not DCD donor situation is. And then if that person is potentially a DCD donor, their family is going to get approached a few hours or maybe a day later about donation. And it's going to be a completely different discussion about the location of withdrawal, the timing of withdrawal, the need for potentially other workups, interventions, et cetera. And so if palliative care is able to sort of bridge that and say, this is what it looks like when the withdrawal happens in the ICU, but there's also an opportunity for organ donation in some patients, and it looks a little bit different. Not to try to approach, but more to say that this can potentially be an opportunity or something that can come out of this tragic situation. Then I think that that's the right place to at least introduce the concept that this could be an option, but not to try to actually get authorization. It's more of like a warning shot. So those are my thoughts on palliative care and ethics and their roles in policy development.
Awesome, thank you. We have one here with regards to a PACU withdrawal. Does the patient stay in the same bed from PACU, or are they moved to an OR bed for the procedure?
No, they are moved to an OR bed for the procedure. So even like I've timed it because there is one OPO in our area that they do withdraw either in the ICU or the PACU. And no matter what, so usually what happens is if the withdrawal is outside of the ICU, the pronouncement happens outside of the OR. Sorry, the pronouncement happens outside of the OR in wherever the ICU, the PACU. And then that once pronouncement happens, family says goodbye, they whisk them away, bring that person to the OR, move them over to the OR table, repronounce. That I have never seen that process happen faster than about 7 minutes. So even if your hands-off time is 5 minutes, you really can't make an incision until about 7, because there's always chaos in trying to move the dead person over from one bed to another and then getting them positioned. Then you have to prep and drape. And it's a bit chaotic. So I haven't seen that happen in less than 7 minutes. So instead of having 2 minutes or 5 minutes, you're really adding another 2 minutes. And then you have to get to incision to flush, which at the best of times is about 2 minutes. So you're adding a significant amount of time, especially for your organs that really can only tolerate a short warm ischemic time. So yeah, they do have to move over to an OR bed. You can't do the operation on a PACU bed.
Thank you. Maybe hopefully a quick one here. Is there any actual data on the recurrence of autoresuscitation on a DCD OR?
There's not good data on DCD donors and autoresuscitation. Like nobody has collected that in a systematic manner, but there are some studies that you can look at that look at like time to auto resuscitation. There's one decently recent one in the New England Journal, and basically I think it's in the New England Journal. Basically they showed that there was no evidence whatsoever of auto resuscitation after 5 minutes, and these are in individuals who had withdrawal of life-sustaining treatment, not as DCDs. And that even those who had what they termed very conservatively evidence of autoresuscitation, like one heartbeat or something like that then stopped, none of them regained a perfusing rhythm, meaning none of them regained an actual respiration and heart rate that would be compatible with perfusion and life.
We have one here. I know this is near and dear to you. So can you kind of talk to us a little bit about NRP and the DCD process?
Absolutely. So NRP, for those of you who are not familiar, is normothermic regional perfusion. This is where the donor, instead of doing the rapid cannulation and cold perfusion, what happens is you do a rapid cannulation with oxygenated regional perfusion to the organs, which means it's basically using ECMO as a regional perfusion. You can do it in one of two ways. You can do what's called thoracic normothermic regional perfusion, and that's where you centrally cannulate in the chest, and that's typically done by heart teams. And you go on ECMO through the chest. There is also an opportunity to do it as an abdominal pathway. That's for NRP in the abdominal pathway. That's the one place where you can actually do the withdrawal of life-sustaining treatment in the ICU, because you can place the cannulas in the femoral vessels, and then you place what's called a REBOA, which is a balloon occlusion device, into the aorta. All of that can be done either during the hands-off period or during or prior to withdrawal with the consent of the family. And then so we do that, and then what happens is, as soon as the patient is confirmed dead, we turn on the perfusion circuit, and we perfuse the organs and move the patient down with that perfusion occurring.
Right. Regarding the proposal for pre-withdrawal of life support femoral cannulation, who actually performs that procedure? Is it the transplant center staff or hospital staff?
So for us, so they're kind of two different camps in the thought process for this. So the OPO I can call them out because I know the OPO in Wisconsin is a very has been a leader in DCD donation. So if you look, I think it's they have a paper that recently came out in the American Journal of Transplantation about liver biopsies on like 300 plus DCD donors. I mean, it's a huge experience. So what they do is they get consent from the family to do a femoral cut down prior to the withdrawal of life-sustaining treatment. And that is done by the transplant team. It's done by the procurement team. They do a timeout, they do the cut down, but they don't cannulate any of the vessels. They just expose the vessels, and that's it. So that is one process. For us, we actually have a third-party team that does our femoral cannulations. So for the abdominal pathway DCD, we use our ECMO team, which is basically our trauma team. They get consent from the family. They discuss the procedure, and they do the procedure. So they're not involved in the provision of comfort care, nor are they involved in the procurement operation. They're like a third-party team. They will, if we go on ECMO, they will come with us to help run the circuit, but their job is to make sure the ECMO circuit functions, not that they don't do any of the procurement stuff.
One more question. Do you have a policy that could be shared? I don't know.
I don't have one to kind of pull up here, but I would be, if you guys, I'll type my email into the chat. If you email me, I can send you a
your favorite.
I can send a policy, and I'll tell you, if you Google DCD policies, I want to say it's one Legacy from California actually has a sample DCD policy that they give to all of their donor hospitals. That is good, like it's a pretty good outline, and it's like the top thing that comes up on a Google search.
All right, maybe one more here. From a clinician's perspective, what is the barrier to consistency in referral requirements? Should the OPOs be making referral requirements more broad to initiate the referral of potential DCD patients? Is there a lack of time? Is it a lack of convenience? What do you think?
So we're actually trying to figure that out right now. We have, we're looking at all the patients who were referred to STA in a 1-year time frame, and when that referral happened and sort of what were the circumstances around the referral. And this was prior to the implementation of a couple of things that I'll talk about that I think actually bring down those barriers. So what we are seeing, at least in the early data, we're only about halfway through it, is that a lot of referrals happen after cardiac time of death. So it means that these referrals are way too late to the game, or some of them occur within an hour of withdrawal of life-sustaining treatment. That's probably not going to give the OPO any time to make approaches. So there are a couple of things that have a couple of process improvements that have been done at our hospital, and hopefully will go out across the system. One is something called Starter. So that is an automated referral system that works in the background of Epic and automatically allows for automatic referral of donors into to STA. So when you do that, the likelihood is if you bring down the barrier of the nurse doesn't have to call STA and wait on hold and do all those other things, if they can just push a button, then that's going to make the referral process much easier. So we've rolled out Starter, and we're going to see if after a year of Starter, that process has changed when the referrals happen. I think the other barrier is probably, and I'm not on the OPO side, but it's probably having enough people available to actually review the referrals in a timely manner and then get somebody on the ground decently quickly. Because we're a high volume donor hospital, we have an in-house team, which makes all the difference in the world. Our in-house team from STA does education, they do outreach, and they're available 24/7 to meet with families, and so and to evaluate donors. And so I think that having an automated, easy referral system and then having an available team are two barriers that two things that can bring down the barriers.
Sorry, we're coming up on the top of the hour here. So we do have a couple more questions in here. If you could hold on for a minute, or do we need to wrap it up?
Let's do one more. We can do one more.
Do you have any physicians who have had a problem with waiting in the OR until cardiac death?
Yeah, so there is, I mean, it's a big drain. And my assumption is this question is about if there are physicians, like ICU physicians, who have a problem waiting. So sometimes that is one of the barriers to doing a withdrawal of life-sustaining treatment in the OR, is that you have to take a physician out of the ICU for an hour and a half, 2 hours, whatever that time frame might be. So yes, I have seen that as a barrier. I usually, by the time I get there, we've already sorted out the situation, but sometimes that actually, the availability of an ICU physician is the determining factor for when the donor operation is going to be. So it's definitely a barrier, but it's something that that our OPOs in this area try to sort out before they get the procurement teams on the ground.
Awesome. Thank you so much, Dr. Wall. I think at this point, I can turn it back over to Deanna for a little wrap up. If there's anything else you need from us, Deanna, let me know.
Oh, no, thank you. I just want to say on behalf of the Alliance team, I'm sure everybody who's in attendance today, thank you both so much. Dr. Wall, that was a fantastic presentation. I think a lot of great recommendations shared. So I appreciate you taking the time to be with us today and share all that valuable information. Okay, sorry, was someone jumping in? Okay, so thank you so much for joining us, and thank you also for offering to be a resource to folks. I did see that you popped your email into the chat. So for those of you who did have some questions that maybe you submitted ahead of time or did get a chance to pop in the chat, you can feel free to send those our way. And if Dr. Wall wouldn't mind, we'll ask her to address some of those questions, or certainly you can feel free to reach out to her as well. But again, thank you both ladies so much. And for everybody who's still hanging on with us, thank you so much for joining us. And we look forward to seeing you all again in the future. Take care, everyone.
Thank you.
Thank you.